Hello, this is Dr. Andy Higgins, and this video segment is to try to address the frequently asked question of what type of breast cancer do I have? So here in Central Oregon, most women get their biopsy done by the radiologist, and a day or two later the radiologist calls to give them the information. Was their biopsy negative or was it positive? And once that radiologist tells them it's positive, and sometimes it sounds a little bit like Charlie Brown's school teacher on Peanuts, and it's and people sometimes shut down and can't quite process things beyond that. So one of the first questions that many ask me is, well, what type of breast cancer is this? So I think of it into two categories. We have invasive type breast cancers and we have non-invasive type breast cancers. Invasive type breast cancers mean that the cancer cells have the ability or potential to migrate or metastasize. They can spread to other places of the body. Typically, they spread to the lymphatic channels and deposit in lymph nodes. That's why we have an obsession with lymph nodes and sample lymph nodes at the time of surgery to make sure cancer hasn't spread. But these breast cancer cells can also get access to the bloodstream, and you may have circulating breast cancer cells in the system at the time of the diagnosis. Most of us that treat breast cancer presume women have those circulating cells, and most all women will have some sort of a recommendation for a systemic treatment, whether that's an anti-estrogen pill like tamoxifen or aromatase inhibitors, or whether that's the need of even a chemotherapy to obliterate those cells in the system before they deposit in another body part, which is termed a distant metastasis, stage 4 disease. Within invasive type breast cancers, they can all be termed invasive mammary carcinomas, but more specifically, they either come from the ductal cells or lobular cells. Ductal cells are the cells that line the tube that carry breast milk to the nipple. Lobular cells are the ones that generate and make the milk. Invasive ductal carcinoma is the more common variety. It's the bulk of about 75% of invasive breast cancers tend to be ductal. Lobulars are a little less common. They behave similarly. From a surgeon's perspective, invasive ductal carcinomas tend to be a little bit easier to contend with in a way because they tend to form more of a cancer ball or a cancer mass. Invasive lobulars, they tend to be my sneaky critter. They tend to present a little bit later because their growth pattern is more single lines of cancer cells rather than a mass of cancer cells. And so it can have a more insidious, sneaky, hidden growth pattern. Doesn't necessarily form a mass right away, may form a subtle thickening, may be a little harder to detect on a mammogram. So while invasive lobulars tend to be very sensitive to anti-estrogen therapies, they frequently can present later and have a more advanced stage at the time of diagnosis only because they're more insidious growth pattern. So that's the bulk of invasive. Then there's the non-invasive. Within the non-invasive, it's really ductal carcinoma in situ, DCIS. DCIS is considered a non-invasive form of breast cancer. It does not have the ability or potential to migrate or metastasize. It doesn't go to other places of the body. It does not shorten lives. There's never chemotherapy that is utilized for DCIS. DCIS is a big local problem, meaning it can recur in the breast, even after surgical excision, even after radiotherapy to follow that, or even after total mastectomy, there is a risk of it recurring in the breast. Now, here's the sneaky thing with the DCIS. If we do see a local recurrence in the breast, half of the time it comes back as that same DCIS, but half of the time it can come back as an invasive breast cancer. So it can one-up on us if we allow it. Well, I thank you for your attention, and I hope you found this video helpful.